Hello all, good evening. I hope my voice and video are clear. I hope everything is good from my side. Okay, so without any further delay, we'll start with the session. Welcome to one more Prof Exam Made Easy session, and this time we'll be discussing about corticosteroids. How much important is this topic, my dears? As usual, we'll be going through certain flowcharts and mind maps and certain diagrams. And the notes which we are going to be giving up here would be more than enough to write it up in your main exams, especially your prof exams. This topic is going to be very much important for the secondary students and also for the final year students. And please make sure that you take down these notes. We'll start with the first one, steroids. See, as per steroids is concerned, most of us will be knowing that the whole of the flow chart, like how it is going to be synthesized and how it is going to get released, will be starting up from the pituitary glands. So from the pituitary, as we know, there will be release of POMC, pro-opiomelanocortin molecules. From the pro-opiomelanocortin molecules, there will be release of corticotropin. Corticotropin in turn will be stimulating the adrenal cortex. Thereby, it will be releasing out four important molecules from its surface. One is your glucocorticoids, mineralocorticoids, androgens, and estrogens. What exactly is the function of these glucocorticoids? Glucocorticoids are primarily responsible for metabolism and immune system modification, or else we can also it can also get involved in terms of inflammation too, especially your anti-inflammatory properties. So for metabolism and immune system modulation, we need glucocorticoids. Mineralocorticoids primarily for salt retaining mechanisms. What exactly does it mean? Salt retaining mechanisms. It's going to be retaining back sodium and water, thereby it might increase the body's water content and salt content. Androgen, which is responsible for male sex hormones, whereas estrogen, which is actually the female sex hormones, thereby the secondary sexual characteristics is going to get developed up further. Now, which one is the major glucocorticoid released out? The major glucocorticoid released is cortisol. Similarly, the major mineralocorticoid released is your aldosterone. Major male sexual hormone is going to be DHEA, dehydroepiandrosterone, DHEA. Whereas the major female sexual hormone released out is androstenediol. These are the primary points which is important. Actually, we are still stuck up in physiology. I'm just trying to explain how exactly those releases occurs and what are the pharmacological perspectives pertaining to it. Now, as usual, we'll be drawing up the bigger flowchart, my dears, but don't worry. I'll be targeting more on the pharmacological perspectives alone. So as usual, this bigger flowchart of how your sex hormones, glucocorticoids and mineralocorticoids are getting synthesized. The whole flowchart will be starting up with cholesterol. So cholesterol will be converted, or from which pregnenolone will be synthesized. From pregnenolone, 17-hydroxypregnenolone might be synthesized with the help of 17-alpha hydroxylase enzymes. Again, from 17-hydroxypregnenolone, dehydroepiandrosterone, that is DHEA, will be synthesized. This will be happening with the help of 17 and 20 lyase enzymes. I'm not going to be writing out all the enzymes names. Let's just target more on the clinical perspectives, which is important as per drugs are concerned. Prednisolone on turn will be converted to progesterone. Similarly, 17-hydroxyprednisolone might be converted to 17-hydroxyprogesterone. This will happen with the help of 3 beta dehydrogenase enzymes. 3 beta dehydrogenase enzymes. Similarly, progesterone will be converted to 11-deoxycorticosterone, whereas 17-hydroxyprogesterone will be converted to 11-beta-deoxycortisol. So do we need to write down this whole flow chart? It's not a must, guys, because we have crossed up the physio. Now we are in pharmac. It is not a must for writing out this whole flow chart, but for certain drugs, it might be asked up in your short notes or in 2 marks or even in MCQs too. For understanding the mechanism of those drugs, I'm going to be writing up in detailed perspective here. This step will be catalyzed by 21 alpha hydroxylase enzymes. Again, 11-deoxycorticosterone from which corticosterone will be synthesized, and 11-beta-deoxycortisol from which cortisol will be synthesized. This step is catalyzed by 11-beta hydroxylase enzymes. Is that clear? From corticosterone, we know aldosterone will be synthesized. So we have synthesized our mineralocorticoid. We have synthesized your glucocorticoid, as we explained the major glucocorticoid. And of course, from this DHEA, there will be synthesis of testosterone, which in turn will be producing estradiol. So the sex hormones also is going to be synthesized. Everything, the starting point is going to be cholesterol. Now, how do we remember it, my dear? So simply just remember 173, 2111. 173, 2111. This is the sequence of the enzymes involved in the major synthesis of glucocorticoids and mineralocorticoids, which is, as we can see, 17 or 173 and 2111. Remember that 173 and 2111 is the way in which we can easily remember it. Now, what are the drug names which is going to be inhibiting? Let's start with the first one. We have some drugs which might be inhibiting both of these enzymes, 17-alpha hydroxylase and 17-20 lyase enzymes. This is getting inhibited by abiraterone. Abiraterone is a drug which tend to inhibit 17-alpha hydroxylase and 17-20 lyase enzymes. The conversion of cholesterol to prednisolone, this first step itself will be inhibited by aminoglutathione. Aminoglutathione is the drug which might be inhibiting the synthesis of prednisolone from cholesterol directly. And the third step, the drug which might inhibit 3-beta dehydrogenase enzyme, is your azole drugs. I hope you remember about azole drugs. These drugs are antifungal drugs like ketoconazole, itraconazole. Of course, it also has got some issues or with interference with the synthesis of these molecules, and that's why azole tend to have this particular mechanism. Whereas the last one, 11-beta hydroxylase, is inhibited by metyrapone and etomidate, the anesthetic agent etomidate. These are all the drugs which might be acting up while the synthesis of glucocorticoids or mineralocorticoids or sex hormones is going to be taken care of. So we'll start with the first one. Metyrapone etomidate is the drug which tend to inhibit 11-beta hydroxylase enzyme. Azole drugs will tend to inhibit 3-beta dehydrogenase. Aminoglutathione will inhibit the conversion or synthesis of prednisolone from cholesterol itself. Abiraterone has got dual mechanisms. It will inhibit 17-alpha hydroxylase and 17-20 lyase enzymes. Yep. So first, we have explained about the flow chart of how this sex hormones are getting and also the glucocorticoids are getting synthesized. Next, we explained the flow chart regarding the mechanism of action of individual drugs. It is not regarding to steroids, but drugs which might inhibit the synthesis of steroidal molecules. We'll move to the next one. Let's start with the proper concepts of glucocorticoids, guys. See, glucocorticoids, or simply the primary or major hormone cortisol, is getting synthesized from the adrenal cortex, getting released out into the blood. It tend to follow a circadian rhythm. What exactly does that mean? Based on the time or based on the body's normal circadian rhythm, the hormones or sex hormones release is going to get altered, or the cortisol release is going to get altered. There will be a very high cortisol release, as we can see over here, just before the early or during the early morning times. There will be a greater dip during the night time, and again there will be an increase in the blood levels of these cortisol molecules. Once it is getting released, once this molecules or the glucocorticoids are getting released, this will bind with a molecule named as cortisol binding globulin, CBG, cortisol binding globulin, which is there in the blood itself. Any molecule, if it is getting released, it has to bind with the molecule in the plasma. We used to call them as plasma proteins, but here the molecule in which cortisol is binding is named as cortisol binding globulin. That's the major area in which these molecules will be binding up with. By binding up with that, the further mechanism of action can be expected. But do we have any conditions in which there might be an increased cortisol binding globulin or decreased cortisol binding globulin? CBG molecules might be increased or decreased in certain conditions. It is going to be increased in terms of pregnancy, in terms of estrogen administration, and in terms of hyperthyroidism. In all of these three different conditions, CBG levels is going to be increased. And the vice versa, my dears, it is going to be decreased up in terms of genetic abnormalities, where there might be genetically the patients might get predisposed to decreased levels of CBG, protein deficiency, and hypothyroidism. The only question which has been asked previously is regarding this hyperthyroidism and hypothyroidism. Which one is, in which patients we can expect an increased CBG activity, in which patients we can expect a decreased CBG activity. Hypo will be decreasing, the CBG activity will be lesser. Hyper, the CBG activity is going to be more. It's going to be directly proportional. As simple as that, we can easily remember it. Let's proceed on further. Now let's talk about the mechanism of action of these steroids, how these drugs is going to be producing its particular action inside a particular cell. Consider here is where your glucocorticoids. We have the glucocorticoid molecules here. These glucocorticoids, once it is getting administered, it is going to be binding up with cortisol binding globule. Some molecules is going to be free. Those molecules which are free will tend to cross this barrier and gain entry into the cell. It's going to be gaining entry into the cytoplasm. Now, inside the cytoplasm, there will be defaultly a receptor. This receptor is named as steroid receptor. This receptor is named as steroid receptor or even glucocorticoid receptor. Usually, this receptor, which is present inside the cytoplasm, will be bounded with certain molecules named as HSP90 molecules, heat shock protein 90 molecules. The function of this HSP molecule is to inactivate the receptor. The receptor will not get activated. Now, this receptor will get activated only after it is binding up with the glucocorticoid molecule. So what exactly happens at that point? When the glucocorticoid comes and binds with the receptor, the HSP90 is going to be thrown out from the surface. Once it is getting thrown out, the receptor is getting activated, which in turn will be moving inside the nucleus. Thereby, it is going to be producing its particular response. So what exactly happens once this glucocorticoid molecule binds with the receptor? As we can see, it will be broken down into two major complexes. Here is where the receptor is, into which the glucocorticoid molecules are getting bounded, and we have the HSP90 molecules which are getting separated. Now, this active or activated glucocorticoid receptor in turn will gain entry into the nucleus. In turn will gain entry into the nucleus. Not only that, step number one is it gains entry into the nucleus. Step number two, these molecules directly tend to activate NF-kappa B. And what exactly is NF-kappa B? Nuclear factor kappa B. Forget about kappa B, just think about the first two letters. Nuclear factor, which means this is a molecule which is gaining entry into the nucleus, thereby stimulating certain concepts inside the nucleus. So this NF-kappa B, which is released, in turn will gain entry again into the nucleus. Thereby, this will stimulate transcription and translation. Thereby, the further protein synthesis tend to occur. It is going to be stimulating protein synthesis. Now, these molecules in which these areas are getting bounded, I hope you know that here is where the molecules are getting bounded, the glucocorticoid molecules along with the receptors. These areas are named as glucocorticoid response elements. We have seen a question as especially pertaining to this particular concept body, GRE molecules, the particular area in the nucleic acids in which these molecules are binding and producing the response. Those areas are called as glucocorticoid response elements. We used to call them as GRE molecules. These proteins which are getting synthesized is responsible for its mechanism, primarily the anti-inflammatory mechanisms, the anti-inflammatory, anti-proliferatory, and immunosuppressive properties. We have multiple different functions, guys, but primarily I'm going to be writing up three important functions of steroids: anti-inflammatory, anti-proliferatory, and immunosuppressive concepts. And this is the diagram in which you can easily draw it up in your exams to explain about the mechanism of action of steroids. A small recap: HSP stands for heat shock protein. Here is where the receptor is. On the surface, there will be heat shock protein. When the glucocorticoid molecules crosses the membrane, gains entry into the cytoplasm, when it is binding up with the receptor, This HSP molecule is going to be thrown out, receptor gets activated, which in turn will gain entry into the nucleus, stimulates transcription. Second step, it will increase the NF-kappa B molecules, nuclear factor kappa B, which in turn will gain entry into the nucleus, thereby stimulating protein synthesis. And the area in which it is binding will be named as glucocorticoid response elements. Wonderful. Now, what are the drug names which we have currently, which is used in practice? As per drugs, we have three important concepts: short acting, intermediate acting, and long acting agents. All these are primarily based on the duration of action of certain set of drugs. Remember this? This is one important classification, primarily based on the duration of action of steroids. Short acting, we have hydrocortisone, cortisone, and prednisone. Prednisone and prednisolone, both of these drugs are interrelated. Intermediate acting, we have triamcinolone and paramethasone. Whereas long-acting drugs, we have beta-methasone and dexamethasone. Some books are classifying paramethasone as a longer-acting one, but paramethasone is not that much longer-acting as compared to beta-methasone and dexamethasone. So these two drugs will be included under long-acting agents. These are the classification of these drugs. So till now, what we have seen, we have explained the physiology, like how the hormones are getting synthesized from the pituitary, from the adrenal cortex, and what are the major hormones which is released. Next, we explain about the flow chart and the drugs affecting synthesis of these corticosteroids. Third, we explain about the mechanism of action of steroids. Fourth, the classification, the actual drug names which is coming under the steroids ones. Moving on to the uses of steroids. To which conditions do we use steroids? We can mostly be classified under two major concepts: adrenal uses and non-adrenal uses. Anything which is related to adrenal glands. Of course, glucocorticoids or be it mineralocorticoids, it's going to be absolutely replicating how an adrenal cortex is behaving. That's why in terms of adrenal insufficiency, primary adrenal insufficiency, we can administer a combination of glucocorticoid and mineralocorticoid therapy. Glucocorticoid and mineralocorticoid therapy both are given together because this patient is suffering from adrenal insufficiency. So what is sufficiency or what insufficiency we can expect? Both gluco and mineralocorticoids. That's why we give both of these drugs together for these patients. Glucocorticoid, within glucocorticoid, which is mostly preferred, hydrocortisone is preferred because this is one important drug which has got maximum mineralocorticoid property. Similarly, within mineralocorticoids, which is mostly preferred, fludrocortisone is preferred. Fludrocortisone is preferred out of all the mineralocorticoids. Both of these drugs are given together for treating adrenal insufficiency. What about non-adrenal uses? This is very important question, guys. Uses of corticosteroids itself might be a short note for you. Now, for remembering this, adrenal insufficiency, you can easily remember it. What about non-adrenal uses? We are going to be explaining that with a diagram. This is a simple diagram. I don't expect you to draw this diagram in the answer sheet because I don't know how the exam correctors know. I don't know how they're going to be feeling like. This is just like for the remembrance purposes. This is, consider this is a human, we're going to be starting from the top. The first area is your eyes, thyroid, lung, GIT, kidney, skin, bones and joints. We have multiple different uses of it, and I've given you all the areas in which we can utilize these steroids. Let's start from the top: eye, thyroid, lung, GIT, kidney, skin, bone and joints. So remember this in the same sequence. Okay, what about eye? In which conditions do we use steroids? In terms of any inflammations which is pertaining to uveitis or even optic neuritis, we can utilize steroids. Any inflammation regarding these areas, we can use steroids. Thyroid, of course, we know if the drug name, if the condition's name is ending with ITIS, that stands for inflammation. So thyroid, which means for thyroiditis, we can utilize this steroids because it has got anti-inflammatory potentials. Lung, especially, it can be used for bronchial asthma and fetal lung maturation. This is a question which has been asked previously, my dears. Fetal lung maturation, which drug do we use? We can use steroids. GIT, inflammatory bowel disease, to suppress the inflammation, we can use steroids again. Kidney, in terms of nephrotic, most famous use which is currently being there in the market, steroids. Skin, in terms of psoriasis or in terms of dermatitis, in all of these conditions we can utilize steroids. Bone and joint, again in terms of arthritis, joint inflammation, or even bursitis. I hope you know about bursitis, inflammation of the airspace cavity. For all these different, we can use steroids. You can, with this you can easily remember for what all different conditions we can use steroids. Certain other uses are also there. I'll be drawing that on the left hand side of this image. This can also be used for allergy. In terms of any allergic inflammations, we can, to treat the allergic reactions, we can use steroids. Apart from that, we can simply remember it like for any types of inflammation, or in terms of transplant, any organ transplant to suppress the immune system, we can use steroids. And the third one, in terms of carcinoma, we can use steroids, except one particular carcinoma, and that is Kaposi sarcoma. Except Kaposi sarcoma, for all of the other cancers, we can utilize steroids. Steroids mostly is being used for vomiting also, guys. For in terms of nausea, vomiting, we can administer steroids, especially dexamethasone, anti-cancer drug-induced vomiting. That should not be administered if the patient has been diagnosed with Kaposi sarcoma. These are the different non-adrenaline or non-adrenal uses for steroids, guys. So simply in this page, we have explained about what are the adrenal uses and non-adrenal uses of steroids. Now moving on to the last part of this session, let's talk about the adverse effects of steroids. See, we are going to be classifying the whole of adverse effects into two major types. Adverse effects which can be seen for a shorter duration of therapy or less than 14 days of duration of therapy, and adverse effects which can be seen when it is being used for more than 14 days of time. Less than 14 days of time, we can expect these three major adverse effects. As we can see over here, patients might develop hypomania, acute peptic ulcer, or acute pancreatitis. This one is extremely severe, guys. We have seen lots of patients who are suffering from severe abdominal pain because of acute pancreatitis, post regular use or post high dose of steroids whenever patient has been administered. Now, more than 14 days of therapy, that's an important statement. We have seen a mnemonic, guys. Corticosteroids is the mnemonic from which you can remember all the adverse effects of steroids. But I'm a little bit skeptical in that adverse effect, because usually designing a mnemonic from the particular drug's name, usually it will not be that much effective, because corticosteroids contains like corticosteroids, two C's are there. Which C will come for which? Usually it's a bigger issue for that. So how I remembered is totally all of the adverse effects can be classified into four major subheadings. These steroids will be producing erosion of something in the body. It increases something in the body. It decreases something in the body, and certain other adverse effects. Let's start with the first one. It produces erosion of bone. It produces erosion of bone. What type of erosion? Patients might develop avascular necrosis of femur head. This is a very famous question, my dear. What type of bone deformity patients might develop when they are under a long-term steroid therapy? Avascular necrosis of femur head. GI mucosa, patients might develop peptic ulcer disease. That is the reason why these drugs are contraindicated in terms of osteoporosis and contraindicated in peptic ulcer disease. Good. In a single shot, we're going to be explaining about the adverse effects and the contraindications for the use of steroids. It increases something in the body. Yes. What are the different points which is going to be increased? It increases pressure, which means intraocular pressure. It increases blood pressure. It increases intracranial tension, or ICT is also going to be raised. So what is the clinical implication of it? Because it is increasing the pressure, it is contraindicated in glaucoma, guys. Because IOP is getting rise, so glaucoma, it is contraindicated. Blood pressure is getting rise, so hypertension, these drugs are contraindicated. Intracranial tension, that's why in terms of traumatic brain injury, TBI, we used to call it as TBI, traumatic brain injury, steroids are contraindicated. Even if the patient develops a cerebral edema, Even if we want to administer it, even if you need to administer a steroid, we have to start at extremely low doses and a high caution has to be maintained. To prevent all these things, we can simply administer an osmotic diuretic to maintain the edema. That's why steroids has been farly replaced by osmotic diuretics like acetazolamide or mannitol. Most of the drugs are always been there. Fluids is going to be increasing blood volume. Blood volume will be increased, which again is an indication for the contraindication, which is again a contraindication for congestive cardiac failure and renal failure. So because it is increasing the fluids, heart failure we cannot administer, renal failure we cannot administer a steroid. It increases hair, which means hirsutism. Of course, we know alopecia means loss of hair, hirsutism means hair growth. Mood, not the mood which you think about, this is about psychosis. Okay, this is about psychosis. We used to call them as steroid psychosis, guys. Sodium is going to be producing hypernatremia because the levels are getting increased. We know that these are glucocorticoids or simply steroids, and we have already explained that's the reason why we are talking from physiology, my dears. Mineralocorticoids, I hope you remember that aldosterone, what's its primary function? Salt and water retention. That's what its primary function. So whenever salt is getting retained, which means sodium is getting retained. When sodium is getting retained, in exchange, there should be one more positive ion which is let out from the body because Na is a single positive ion. Of course, most of you would have guessed if sodium is getting retained, what ion is going to be let out? K plus is going to be let out. Fantastic. So when K plus is going to be let out from the body, what can be expected in the patient? Hyperkalemia or hypokalemia? Beautiful hypokalemia. We'll be discussing that in the next page. The levels, what are the levels which is going to be decreased by steroids? Option A or first one, we're going to be talking about height. Of course, we know there will be growth retardation in children. We know that steroids can be given for bronchial asthma as an inhalational therapy. Even when it is given via inhalational route, children might land up in growth retardation. Immunity. What type of immunity is going to be suppressed? Cell mediated immunity will be inhibited more than humoral immunity. So, what is the clinical implication of knowing it? Because it is going to be suppressing the immunity, it is contraindicated in varicella, in terms of herpes infections. In terms of varicella and herpes, because it might get worsened out when the immune system is getting suppressed, in those conditions, steroids are contraindicated. Of course, we know insulin. So, what is the clinical implication? It's going to be contraindicated in diabetes mellitus. Insulin is contraindicated. Steroids are contraindicated in diabetes mellitus because it's going to be decreasing the levels of insulin. Potassium levels is going to be decreased, so patients might land up in hypokalemia. Calcium levels also is going to be decreased, so patients might land up in hypocalcemia. Good. What are the other adverse effects? Also, patients might develop striae and cataract. What's the concept of striae? Especially whenever a drug is given as topical therapy, patients might develop striae. As we can see, like when you will go for a weight loss, we can see lots of white marks, stretch marks, which has been there. Similarly, like that, we can see striae marks throughout the trunk. This is primarily seen when you administer steroids as a topical therapy, and this topical therapy steroids will be producing collagen loss. Well, that is one of the reasons why patients might develop striae. Cataracts. This drug on a long-standing use, patients might develop posterior subcapsular cataract. A famous one, my dears. What type of cataract is associated with steroid use? PSCC. PSCC, we used to call it as posterior subcapsular cataract. Remember this very important one liner. You might land up in an MCQ based on this particular point. The last one, patients might develop seizures. Patients might develop seizures, and that's the reason why these drugs are contraindicated in patients who are known cases of epilepsy. Who are known cases of epilepsy, these drugs are contraindicated. Good. So what's the take home point till now? So we have discussed about all the points about steroids. We explained about what's the physiology behind it, the like the flow chart of how it is getting synthesized, drugs which might be inhibiting the synthesis of steroids. Then we explained about the mechanism of action, the classification drugs, the uses of it. We classified it in a simple way: adenal and non-adenal uses. Then we explained about the adverse effect of it, short-term use, what can be expected, long-term use, what can be expected. These are all the different points regarding steroids, guys. And when you try to recall for the main exams, I request you to go through this video in like 1.5x or 1.75x. You can just fastly go through all the points. Steroids is a very important question for the exams. When the questions is being asked for the long answer, make sure that honors or distinction is under your radar. Good night and all the best. We'll meet up in one more session. Bye bye.